So coming to the second part, the next question is a 26-year-old man brought to emergency following a road traffic accident. He complains of left upper abdominal pain and left shoulder pain, and he is alert. Pulse is 118, blood pressure is 160, abdomen tenderness in the left hypochondrium, and fast focused assessment with sonography for trauma shows free fluid in the abdomen. What is the most likely injured organ? So in a road traffic accident, the bowel injury is very common. In that, if it was a car and if it is a dashboard injury, mesenteric injury is most likely. Otherwise, our organs like liver, spleen, kidneys, they all can get affected. But here, based on the location, which is left upper abdominal pain, free fluid in the abdomen, tenderness in left hypochondrium with left shoulder pain, that is more likely to be of splenic injury. Okay, that is spleen. And that sign particularly is called the Kerr sign. K-E-H-R. Okay. Due to the phrenic nerve involvement, the shoulder, the pain can be referred to the shoulder, tip of shoulder as well. That is called Kerr sign, which is seen in splenic injury. Okay. Next question, a 60-year-old man presents with a painless swelling in the right groin for 6 months. Swelling appears on standing and coughing, reduces on lying down. So, pulsatile a swelling which can be elicited with cough or increase in abdominal pressure, which is appearing on standing, reducing on lying down. What is that classical of? It's a hernia, right? Hernia. Hernia is protrusion of the abdominal contents through a defect in the abdominal wall. Okay, so it can be an incisional hernia, it can be an inguinal hernia, it can be a femoral hernia. Most common hernia overall is inguinal hernia. Right? Swelling is above and medial to the pubic tubercle. Now, based on the location, you can differentiate that. Below and lateral to the pubic tubercle is the location for the femoral hernia. Above and medial is the location for the inguinal hernia. Cuff impulse is present. What is the most likely diagnosis? So now, since it is above and medial to the pubic tubercle, it is a direct inguinal hernia. Indirect inguinal hernia is coming through the sac and the inguinal canal, and it is protruding. It can even reach the scrotum. But here, this is due to the deficiency in the abdominal wall itself, and that is direct protrusion of the abdominal content through that defect. That is called direct inguinal hernia. Femoral hernia is below and lateral to the pubic tubercle. Hydrocele is not the case here, right? Hydrocele, varicocelar, or scrotal swellings. So here it is a direct inguinal hernia. You have your Hasselbalch's triangle. More medially will be your direct inguinal hernia. Laterally will be your indirect inguinal hernia that will be coming through the inguinal sac and can reach even up to the scrotum. Inguinal canal and reach to the scrotum. Next question, a 4-year-old boy is brought with bulging inguinal region, increases on coughing. So again a case of hernia. No other details are provided. What is the most likely underlying pathophysiology? Now they are asking in a boy, in a small child, like a congenital hernia, what is the pathophysiology in that? So in that, it is the patent processus vaginalis. Weak transversalis fascia is the etiology for direct inguinal hernia. It's not weak inguinal ligament, it's not weak or deficient abdominal wall. That all are seen in direct inguinal hernia. In a congenital hernia, it is patent processus vaginalis, and the treatment is you have to do a hernia repair or congenital hernia repair. You have to maybe do it on both the sides because usually it is bilateral. So it is due to patent processus vaginalis. Next question is a 28-year-old woman presents to emergency. Sudden onset severe headache described as worst headache of her life. Now this question was a bit confusing because I think there were 3 or 4 questions, similar ones, described as worst headache of her life. It was different age group and there were little bit differences in the question, but it was all described as worst headache of life. Worst headache of life is usually attributed to subarachnoid hemorrhage or SAH. The headache starts 10 hours ago was associated with neck stiffness and photophobia. That can be there due to the meningeal irritation, but there's no fever, no focal neurological deficits, vital signs are stable. Past history of migraine, but says that this headache is different from her usual migraine. So it is unlikely to be migraine because this is a severe worst pain, so most likely to be SH. NCCT is normal, that is the next step in management. So in SH, if NCCT comes out to be clean, you have to wait around 12 hours after the onset of headache to do an LP so that you can demonstrate xanthochromia. Okay, that is RBC is getting broken down and you can demonstrate that color change. That is the usual thing. Okay, so that is the case. Lumbar puncture to be done. You can't give sumatriptan because this is unlikely to be migraine and you have to rule out SH. Reassuring discharge you cannot do. It's a young patient. If it was SH, it would be more dangerous. So you have to always rule it out. CT angio is once SH is diagnosed, you may have to do a CT angio to see if there is any aneurysm and where is the exact location of the bleed. So it is lumbar puncture to look for xanthochromia, that is bilirubin will be from the RBC breakdown so that you can demonstrate that. It confirms or excludes SH. It is usually done 12 hours from the onset of headache. There were multiple questions, I think 3 or 4 similar question. One had mentioned history of migraine, one did mention that, and the age group was different in a different question. But the options were almost same and every question had an option of lumbar puncture. Next question, a 32-year-old man with recurrent episodes of severe unilateral headache localized to the periorbital region, lasts for 45 to 60 minutes, occurs multiple times a day, often waking him from sleep. So it's a severe unilateral pain in the periorbital region. During attacks, he develops ipsilateral eye redness, that is conjunctival congestion and tearing. What is the most characteristic of these conditions? So what is the diagnosis? You have different types of headache like primary headache and secondary headache. Secondary headache means it's due to some other condition, like it can be in hypertensive patients, it can be due to visual problems, it can be due to an ICSOL, that is intracranial space occupying lesions like a tumor, or it can be primary. Primary again is classified into different types like migraine headache, cluster headache, tension headache, analgesia overuse headache, and their characteristic will be different. Tension headache will be a band-like headache. Migraine headache can be unilateral, associated with photophobia, phonophobia. It can be associated with aura, and nausea, vomiting. Okay, usually in females. But what about cluster headache? It's again unilateral, periorbital pain with conjunctival congestion and lacrimation. It's usually in men. It can last for some time and then it occurs maybe 2 to 3 times a year, but they'll recall the episodes because that will be very severe headache. So this is likely to be cluster headache. So what is the most characteristic of cluster headache is what they're asking. Pulsatile headache aggravated by physical activity. That is a description for migraine. Pulsatile headache is migraine. Ipsilateral Horner syndrome during attacks. Visual aura preceding headache, that is again about migraine. Bilateral tight band light, that is tension headache. So cluster headache may be associated also with ipsilateral partial Horner's syndrome. Okay, so cluster headache can be associated with lacrimation, conjunctival injection, nasal congestion, partial Horner's, that is ptosis and meiosis. So this is a case of cluster headache. And what is the treatment? During acute episode, you can give sumatriptan, you can give hyperbaric oxygen, and prophylaxis is with calcium channel blockers. Okay. Next question. A 35-year-old woman with a dull aching headache that has been present on most days for the past 3 months. The pain is bilateral. of mild to moderate intensity. And it is described as tight pressure around the head. That is a description for tension headache. There is no nausea, vomiting, photophobia, phonophobia. Those are all associations with migraine. And physical activity does not worsen the headache. That is also a part of migraine. So this is classically a tension headache. Neurological examination is normal. Which of the following strongly suggests the diagnosis of tension type headache? Unilateral throbbing pain, that can be a description for migraine. Again, cluster headache can also be unilateral severe periorbital pain. Band-like constriction sensation around the head, that is the description for tension headache, right? Headache associated with lacrimation and nasal congestion, that is again cluster headache. Visual aura preceding headache, that is about migraine. So tension headache is band-like constricting sensation around the head. So you can see that tension headache is around the back of the head, temples and the forehead, almost like a tight hat which is squeezing the head. Migraine typically one side, associated with photophobia, phonophobia, nausea, vomiting, may be preceded by aura. Cluster headache is typically around one eye, associated with conjunctival congestion and injection along with lacrimation and partial horners, which we have seen. Okay, so those were the questions with regards to headache. Next question, a 30-year-old woman diagnosed with irritable bowel syndrome asked about the role of probiotics in symptom control. Which of the following statement regarding probiotic treatment in IBS is true? Probiotic should be of specific strain. There is no role of probiotic. Probiotics should always be combined with antibiotics. Probiotics are always useful in IBS patients. So what is the answer? Probiotic should be of specific strain. To be of use, it has to be of a specific strain. And there was another question wherein you were asked to diagnose IBS. What is the most likely diagnosis? So IBS or irritable bowel syndrome is diagnosed based on the ROM4 criteria. The criteria says recurrent abdominal pain on average for at least one day in a week in the last 3 months associated with two or more of the criteria, which is that is the pain is related to the defecation. It is associated with a change in frequency of stool. So it can be either constipation or diarrhea. That is what we differentiate as IBSD, that is diarrhea predominant, and IBS constipation predominant also. Associated with change in form or appearance of the stool. This criteria should be fulfilled for the last 3 months with symptom onset at least 6 months before making a diagnosis of IBS. So that is your ROM4 criteria. Next question, a 4-year-old boy is brought by his parents with difficulty in retracting the foreskin. Examination, the foreskin is non-retractile, no scarring, no itching, no redness, no signs of infection. Child passes urine normally and has no history of UTI. Urinary tract infection, what is the most appropriate management? So what is this called? It's called phimosis, right? There is phimosis and paraphimosis. And phimosis can be physiological as well as pathological. Pathological means in an elderly patient who had recurrent infections down there, and there is complete, inability to retract the skin. There can be scarring. That is a pathological phimosis. Here it is a physiological phimosis because it can be non-retractile in a 4-year-old boy. It may resolve with age. So in a physiological condition with no other, red signs, no scarring, no itching, you may wait for some time. You don't have to urgently circumcise the patient. So urgent circumcision is not needed. Advise gentle cleaning and daily retraction exercises. That is okay. Topical steroid is only if it is not responding. Possible manual retraction under anesthesia, that should not be done. Okay, so it is advised gentle cleansing and daily retraction exercises because this is physiological. It can be normal up to 5 to 6 years of age. Since there is no scarring, no infection at this point, no active intervention would be required. Management would be reassurance, maintaining hygiene and gentle retraction over time. Next question, a 26-year-old woman presents with easy bruising and gum bleeding for 1 week. She has no fever or weight loss, no recent drug intake. Examination reveals petechiae over the lower limb, no lymphadenopathy or hepatosplenomegaly. Investigation HB is 12, total leukocyte count is 7,000, platelet is 18,000. So there is low platelet count. Peripheral smear shows normal RBC and WBC. What is the most appropriate next step in management? So what does this seem like? A 26-year-old coming with gum bleeding, EC bruising, petechiae. Okay, and there is thrombocytopenia. There is no other association. Okay, so what is this? It is most likely to be ITP, idiopathic thrombocytopenic purpura. So what is the management of ITP? If it's not a major bleed, there is no intracranial bleed, there are no red signs, the patient is stable, you can always start giving steroids. Okay. Platelet transfusion is absolutely obsolete. You should not give platelet in ITP. That may worsen the condition. Bone marrow biopsy before the treatment? No. Splenectomy? No. That is in a very refractory case where it is not responding and there is multiple episodes. Then you may have to go for splenectomy. Otherwise, no, there is no role of splenectomy in a um, stable case of ITP. So it is oral corticosteroids. Start oral corticosteroids. If the option had IVIG, the IVIG is actually reserved for life-threatening bleed, like intracranial massive GI bleed, because I remember there were two questions. One had IVIG as option, one didn't have IVIG. So IVIG is only given if there is life-threatening bleeding like IC bleed. There is need for rapid platelet rise like before urgent surgery. If the patient is pregnant and there is due delivery, and steroid refractory ITP, you can give IVIG. Otherwise, first line always is corticosteroids. A 60-year-old man with profuse watery diarrhea, abdominal pain and fever on third post-operative day following an abdominal surgery. He received perioperative broad spectrum antibiotics. On examination, is dehydrated, has diffuse abdominal tenderness. Lab investigation shows leukocytosis. There is no abdominal distension and bowel sounds are present. What is the most likely diagnosis? So it is a perioperative, post-operative case wherein he had received perioperative broad spectrum antibiotics. Now presenting with watery diarrhea, abdominal pain and fever with leukocytosis. So what is it likely to be? If you're giving antibiotics, most of the antibiotics like clindamycin, cephalosporins, everything can predispose the patient to enterocolitis or colitis, mainly due to Clostridium difficile, right? So again, this is also maybe a condition of Clostridium difficile due to antibiotic use. Postoperative ileus mainly presents with constipation and all. Mechanical intestinal obstruction, again, there will be constipation, not diarrhea. Acute bacterial enterocolitis, that is the case. Paralytic ileus also, not the case. Paralytic ileus usually due to hypokalemia, right? So this is a case of acute bacterial enterocolitis. So if it is Clostridium difficile, how do you diagnose it? With toxin A, right? Toxin A and toxin B and GDH. And then how do you treat? You stop all the offending drugs and give oral vancomycin, and you can give metronidazole, and otherwise you can give rhodoxamicin. These are the treatment for Clostridium difficile, right? And it can be very fulminant condition. It can lead to the colon perforation, and the patient can uh, go into death. Okay. Next question, a 45-year-old man present with severe epigastric pain relating to back associated with vomiting. What did we told about this condition? Epigastric pain relating to back associated with vomiting, most likely to be pancreatitis. On examination, tachycardic hypertensive. Okay, that is a severe pancreatitis. Abdominal tender in the epigastrium lab investigation revealed serum amylase and lipase elevated. Amylase can be elevated in many other conditions, so lipase is the more specific marker for this pancreatitis. More than 3 times the upper limit of normal. What is the next best step in management? So amylase is more sensitive, lipase is more specific. What is the best next step in management? In pancreatitis, what would you do first? You always keep the patient NPO and start IV fluids. So start aggressive intravenous fluid resuscitation. CECT is not needed immediately. Broad spectrum antibiotics are not indicated. ERCP is also not indicated. So it is IV fluids. Patient has acute pancreatitis with shock, so your basic management prioritizes ABC, airway, breathing, circulation. So you have to restore the intravascular volume by giving aggressive fluid resuscitation. Early aggressive IV fluids, preferably ringer lactate, can reduce mortality. Imaging is not first when the diagnosis is clinically and biochemically clear. Antibiotics are not indicated in uncomplicated acute pancreatitis. ERCP is only if gallstone pancreatitis with cholangitis or persistent obstruction is present, and you have to first do an MRCP to localize the site and then go for invasive treatment. But that is not during the acute episode when the patient requires management of ABC. Next question, a 28-year-old man is newly diagnosed with diabetes mellitus during routine evaluation. He is asymptomatic and non-ketotic. Investigations show anti-GAD antibodies are negative. So anti-GAD antibodies are the autoimmune antibodies. So this is not autoimmune. Autoimmune is which one? Type 1 diabetes. Because the patient is 28, we have to differentiate between type 1, whether it is type 2 diabetes, whether it is MODY, that is maturity onset diabetes in young. That means more or less likely to like the type 2 characters, which is presenting early on in young. Or LADA. LADA is latent autoimmune diabetes in adult. That means type 1 presenting later in life. But this is not type 1, not LADA also, because antibodies are negative. C-peptide is also normal. That means the pancreatic reserve is normal. The insulin production is normal. There is mostly insulin resistance, which is a characteristic of type 2 as well as MODY. There's no history of autoimmune disease, no features of insulin resistance. What is the most appropriate next step in management? So they've mentioned no features of insulin resistance, which is classically seen in type 2 diabetes. So here in a young or adolescent or a young adult, that is 28-year-old, who is first diagnosed as a case of diabetes, you have to differentiate between type 2 DM and MODY so as to make a improvement in their overall status, so as to give a better treatment choice. Because if it was type 2 diabetes, you can start with metformin and other OHAs. If it was type 1 diabetes, your treatment of choice is insulin. Okay. So you have to first make a diagnosis and then start treatment. So the options are start lifestyle modification when performing. That would have been the case if it's like a 40-year-old man first diagnosed with diabetes, more likely to be type 2 DM. Then you can start with metformin. Start insulin therapy, there is no point because C-peptide is normal, the insulin production is normal, the insulin resistance also, and there are no features. Sulfonylurea therapy, no, unless you make a diagnosis, it would be uh, unjustified to give the treatment. So screen for maturity onset diabetes of young. Okay, that is the option. Because it is young age, anti-GAD is negative, so it is not type 1, not LADA. Normal C-peptides are preserved endogenous insulin secretion. No insulin resistance features, which is atypical for type 2. In type 2, there will be insulin resistance features. So this raises suspicion of MODY, maturity onset diabetes in young. Therefore, genetic screening is the next step. You could give lifestyle modifications plus metformin had it been type 2 DM, but the diagnosis is uncertain here. Insulin is not indicated with normal C-peptide. Sulfonylurea treatment would be started only once you confirm the subtype of MODY, because MODY has different subtype and that has different treatment also. One type of MODY does not require much treatment. One type can be treated with sulfonylurea. Okay, so the treatment varies, so you have to do a genetic testing for MODY. Next question, a 22-year-old man with type 1 diabetes with vomiting, abdominal pain and altered sensorium. On examination, dehydrated, has deep, rapid breathing and fruity odor on his breath. So what is this? Fruity odor. So it can be a ketoacidosis because the patient is of type 1 diabetes. Ketoacidosis more common in type 1 than type 2, right? Investigation reveals blood glucose 480, arterial pH 7.12, so there is acidosis, metabolic acidosis, bicarbis 10, ketones are positive. So it is diabetic ketoacidosis. It's like a high anion gap metabolic acidosis. What is the most appropriate first step in management? So even if it is HHS, uh, hyperosmolar, hypertonic, uh, this thing, or diabetic ketoacidosis, in both the case, you have to give IV fluids. That is the first line management. Okay, so administer IV fluid. Begin aggressive IV fluid resuscitation. Intravenous sodium bicarbonate is not usually indicated as first line management in diabetic ketoacidosis unless the pH is very low, like less than 7.1. Okay, it's not again first line management. It can be a little bit improvement in the patient only. That is not started straight away. Start IV insulin infusion. No, you have to first give enough fluids because they will be volume depleted. You have to check for the potassium levels, correct the potassium before starting of insulin, and if the patient is going hypoglycemic or less than 200, you have to start dextrose alongside insulin so as to maintain the glycemic status while controlling the acidosis, right? Administer IV potassium immediately, that is after you check for the potassium level. The first line management, the first concern is always the intravascular volume status. So begin aggressive intravenous fluid resuscitation. Next question, a 17-year-old boy presents with polyuria, polydipsia, weight loss and fatigue for 2 months. His lab investigation reveals marked hyperglycemia. So polyuria, polydipsia, weight loss. This is the triad in diabetes mellitus. And there is marked hyperglycemia. What is the most characteristic of type 1 diabetes? That is what they are asking. So in type 1 diabetes, the characteristic feature is presence of ketosis. Obesity at presentation usually with type 2. Normal or elevated C-peptide level. C-peptide will be usually low in type 1 diabetes because it is decreased insulin secretion because of antibodies against the beta cells in pancreas. Insulin resistance as a primary abnormality, that is again in type 2 diabetes. So ketosis is a feature of type 1 diabetes. So it is the presence of ketosis. Next, a 16-year-old girl comes to your clinic for routine health checkup. She has no significant past history, otherwise healthy. She asks about ways to prevent future infection and cancers. So the age is 16 years. Which of the following is most appropriate preventive intervention at this age? HPV vaccination, tetanus booster only, annual pap smear starting immediately. No, annual pap smear is started only from 21 years of age, right? Mammography screening, that also started beyond 30 and all. So tetanus booster only, that doesn't make sense because at 15 they would have gotten it. And the more likely option is HPV vaccination. 11 to 19 years of age in both boys and girls, you can give HPV vaccine. 2 doses would be given. Okay, so it is HPV vaccination to prevent which cancer? Cervical cancer. 16, 18, 31, 33, those are the strains which are high risk for cervical cancer. 29-year-old woman presents for routine health checkup. She's asymptomatic. Last pap smear was done at the age of 26 and was normal. No history of immunosuppression, sexually active. What is the most appropriate next step? So you have to know the screening of the cervical cancer. Starting from 21 to 30, you can do pap smear every 3 years. You don't start HPV DNA testing at this age. Beyond 30, you either can do 3 yearly pap smear or you can do a couple test of pap smear plus HPV DNA every 5 years. That is how you do. Beyond 65, you can stop screening. Okay. So now what is the sense? She's 29. She had a pap smear 3 years back. So now it is her due time for pap smear. She do not need an HPV DNA testing because that is done after 30. Okay. And core testing is also done after 30. So this is the screening. Under 21, no testing needed. 21 to 30, pap smear every 3 years. 30 to 65, pap smear every 3 years or pap plus HPV, that is core testing every 5 years. Beyond 65, you can stop. Next question, a 30-year-old woman comes for counseling because she is worried about her cancer risk. Family history is significant for ovarian cancer in maternal aunt, breast cancer in her mother. So there is both breast cancer and ovarian cancer in close family members. She is otherwise healthy. Most appropriate next step in management. So does this ring a bell? Both ovarian and breast cancer and close relatives. What do you need to do? You have to screen for BRCA1, BRCA2 mutation. Okay. Routine mammography, no, because that will not identify her genetic predisposition to cancer. Prophylactic bilateral mastectomy, no. Chemoprevention tamoxifen without testing, no. So it's BRCA1, BRCA2 genetic testing. And what are the indications for doing that? Breast cancer diagnosis before the age of 50, bilateral breast cancer, occurrence of both breast and ovarian cancer in close family members or in that patient itself, tubal and peritoneal cancer, breast cancer in more than one male relative, multiple cases of breast cancer in extended family, one or more family members with two primary types of BRCA related cancers. It can be endometrial, it can be even prostate cancers, and Ashkenazi Jewish ethnicity. These are the conditions wherein you have to offer BRCA and BRCA2 genetic testing. Next question, a 25-year-old man with painless swelling in right side of his neck reports night sweats, intermittent fever, and unintentional weight loss. What are they called? They are called B symptoms, right? On examination, there are multiple firm non-tender cervical and supraclavicular lymph node. So multiple lymph nodes, no hepatosplenomegaly. Hemoglobin is 11, WBC is 8,500, platelet is 2,50,000 in ESR is elevated. What is the most likely diagnosis? And the image was also given. What is this? This is a classical Reed-Sternberg cell. Reed-Sternberg cell, and that is seen in Hodgkin lymphoma. So this is a case of Hodgkin lymphoma with B symptoms. Not tubercular lymphadenitis. Tubercular lymphadenitis can be a matted lymph nodes, right? Can be long-standing. There can be recurrent fevers. Infectious mononucleosis, no. There are atypical lymphocytes seen in infectious mononucleosis, not the Reed-Sternberg cell. So it is Hodgkin lymphoma, and what we see in that image is called the Reed-Sternberg cell. Next, a question from Ortho. A 45-year-old woman falls on her outstretched hand while walking. She complains of pain, swelling, and deformity of the wrist. X-ray of the wrist is shown. What is the most likely diagnosis? What do you see in this X-ray? You can see that there is some fracture here, right? Can you see? There is a fracture here. And in this image also, you can see the fracture is displaced. Displaced where? Dorsally. So dorsal displacement of distal radial fracture, what is that called? It is called Colles fracture, and it's an extra-articular fracture. If it was intra-articular, it's called a Barton fracture. Smith fracture is reverse Colles fracture, that is ventral displacement of the displaced fractured segment. Galeazzi fracture is distal radial fracture along with radioulnar joint dislocation. Okay, so this is Colles fracture. Smith fracture is distal radius fracture with volar displacement or volar angulation, and that can show a garden spade deformity. What do you see in Colles fracture? You get a dinner fork deformity. Barton fracture is intra-articular of distal radius with displacement of carpus. Galeazzi's fracture of distal third of radius associated with dislocation or instability of the distal radioulnar joint. Next question, a 28-year-old man presents with largely displaced mid-shaft fracture of femur after road traffic accident. On examination, distal pulses are intact. Sensation is reduced in the feet. No other injuries. What is the immediate best management to optimize the outcome? So in a mid-shaft fracture of femur, what are the complications that can occur? It can lead to fat embolism, okay, and the patient can collapse. So you have to manage the patient so as to reduce this complication. So first thing you can always do is immediate reduction with sustained traction. You can't do an immediate surgical fixation. You can't do an immediate casting. You can't simply observe the patient because of the risk associated, right? So reduction with sustained fraction, because displaced femoral shaft fracture has risk of neurovascular compromise, soft tissue injury, and as well as fat embolism. So immediate priorities are to stabilize to prevent further soft tissue injury as well as nerve injury, and assess the neurovascular status. Sustained traction temporarily aligns the fracture, it reduces pain and risk of further nerve injury, and allows time for full pre-op treatment and planning. Surgical fixation is the definitive treatment for sure, but it's not the immediate in unstable or unprepared patients. Initial traction optimizes the outcome. Then from ortho, there were another question of compartment syndrome. There were description of the, what are the features of compartment syndrome? Pulselessness, paralysis, paresthesia, right? Pain out of proportion to the presentation. And what do you do? You measure the compartment pressure. And what is the treatment? It's fasciotomy. You have to release the pressure. And then there was another question on neck of femur fracture. It was an elderly lady who had a trivial fall, and now her leg is shortened and externally rotated. So what is most likely fracture or most likely diagnosis? It was a neck of femur fracture. It has risk of avascular necrosis of head of femur. Next question, a 42-year-old man presents to family medicine clinic with low back pain radiating to both lower limbs. MRI shows lumbar disc herniation with nerve root compression. So the diagnosis is given. It's lumbar disc herniation. There are no red flag signs. There is no bladder bowel involvement. There are no progressive neurological deficit. So what is the best initial management? In a lumbar disc prolapse, is it physiotherapy, NSAIDs and conservative care, immediate surgical consultation, oral corticosteroid? So surgical consultation would be needed if there are red flag signs, right? Like bowel bladder involvement, for progressive neurological deficits, right? Here it is not there. So what is your first management? It is NSAIDs and conservative care, because most of the disc herniations, if it's very small, it's self-limiting. But there are red flag signs when you need to urgently take them to a surgical neurosurgical consult and a spine surgeon, um, like Cody-Quina syndrome, progressive motor weakness, severe intractable pain, bowel bladder involvement. Initial management is always NSAIDs for pain control, short-term rest, and then activity modification. Physiotherapy for strengthening once the acute pain improves. Surgery is only if conservative treatment fails or there are red flag signs. Next question, a 15-year-old boy presents with progressive pain and swelling around the knee for the past 3 months. The pain is worse at night, not relieved by rest. So night pain and swelling around the knee in a 15-year-old boy. What is your first thought? It is osteosarcoma. Usually first comes pain, then comes swelling. And there is night pain also. Okay, that is more characteristic. Not relieved by rest, no history of trauma. Examination reveals a firm tender swelling over the distal femur, because that is more likely location. Distal femur, proximal tibia, with restricted knee movement. X-ray shows mixed lytic sclerotic lesion, metaphysis. Again, this site becomes important. There's some metaphyseal lesions, there are epiphyseal lesions, and there are diaphyseal lesions. Diaphyseal lesion is your Ewing sarcoma. Metaphyseal lesion can be osteosarcoma, and your epiphyseal lesion can be a giant cell tumor, right, of the distal femur with periosteal elevation forming a Codman triangle. Codman triangle, sunburst appearance, these are all classical clues about osteosarcoma. So what is the next best step in management? So diagnosis more likely to be osteosarcoma. So what do you have to do? You have to make a Confirm diagnosis. So start radiotherapy to the affected bone, immediate wide surgical excision of the lesion. Refer for oncology evaluation, treat with NSAIDs and review after 6 weeks. So this seems like a osteosarcoma. You have to do a thorough investigation. So you have to refer for onco evaluation. Okay, refer for oncology evaluation. Next question: a 30-year-old woman, 24 weeks pregnant, present with palpitations and dyspnea. She has non-history of rheumatic mitral stenosis. On examination, her pulse is irregular with a ventricular rate of 140. Blood pressure is stable. There are no features of heart failure. ECG confirms AF. So is a 24 weeks pregnant, already with mitral stenosis, now with AF. What is the next best step in management? Do you start warfarin immediately? Do you perform a transesophageal echocardiography, that is TEE, or electrical cardioversion without anticoagulation, or defer treatment until after delivery? Now you comment the answer of this question. We'll discuss from this question onwards in the next session. So thank you so much.